Hello, and welcome to By the Book, a monthly podcast series from ASCO that features engaging conversations between editors and authors of the ASCO educational book. I'm your host, Dr. Hope Rugo. I'm director of the Women's Cancers Program and Division Chief of Breast Medical Oncology at the City of Hope Cancer Center, and I'm also the editor-in-chief of the education book. On today's episode, we'll be exploring the complexities of grief in oncology and the struggle we experience as healthcare professionals when terminally ill patients are suffering. Our guests will discuss approaches to help clinicians understand and respond to suffering in a more patient-centered and therapeutic way, as outlined in their recently published article titled Oncology and Suffering: Strategies on Coping with Grief for Healthcare Professionals. I'm delighted today to welcome Dr. Keri Brenner, a clinical associate professor of medicine, palliative care attending, and psychiatrist at Stanford University, and Dr. Mikolaj Slawkowski-Rode, a senior research fellow in philosophy in the Humanities Research Institute at the University of Buckingham, where he also serves as director of graduate research in philosophy. He is also a research fellow in philosophy at Blackfriars Hall at the University of Oxford and associate professor at the University of Warsaw. Our full disclosures are available in the transcript of this episode. Dr. Brenner and Dr. Slawkowski-Rode, thanks for being on the podcast today.
Great to be here, Dr. Rugo. Thank you so much for that kind introduction.
Thank you very much, Dr. Rugo. It's a pleasure and an honor.
So I'm going to start with some questions for both of you. I'll start with Dr. Brenner. You've spoken and written about the concept of suffering when there is no cure. For oncologists, what does it mean to attune to suffering, not just disease? And how might this impact the way they show up in difficult conversations with patients?
Suffering is something that's so omnipresent in the work of clinical oncology. And I like to begin by just thinking about what is suffering, because it's a word that we use so commonly, and yet it's important to know what we're talking about. I think about the definition of Eric Cassell, who was a beloved mentor of mine for decades. And he defines suffering as the state of severe distress that's associated with events that threaten the intactness of a person. And my colleague here at Stanford, Tyler Tate, has been working on a definition of suffering that encompasses the experience of a gap between how things are versus how things ought to be. Both of these definitions really touch upon suffering in a person-centered way that's relational about one's identity, meaning, autonomy, and connectedness with others. So these definitions alone remind us that suffering calls for a person-centered response, not the patient as a pathology, but the panoramic view of who the patient is as a person in their lived reality of illness. And in this light, the therapeutic alliance becomes one of our most active ingredients in care. The therapeutic alliance is that collaborative, trusting bond as persons that we have between clinician and patient. And it's actually one of the most powerful predictors of meaningful outcomes in our care, especially in oncologic care. I'll never forget my first day of internship at Massachusetts General Hospital. A faculty lecturer shared this really sage insight with us that left this indelible mark. She shared, as physicians and healers, your very self is the primary instrument of healing. Our being is the median of the medicine. So our very selves, as embodied, relationally grounded people, that's the median of the medicine and the first most enduring medicine that we offer. That has really borne fruit in the evidence that we see around the therapeutic alliance. And we see this in oncologic care, that in advanced cancer, a strong alliance with one's oncologist truly improves a patient's quality of life, treatment adherence, emotional well-being, and even surpasses structured interventions like psychotherapeutic interventions.
That's just incredibly helpful information and actually terminology as well. And I think the concept of suffering differs so much. Suffering comes in many shapes and forms, and I think you really have highlighted that. But many oncologists struggle with knowing what to do when patients are suffering but can't be fixed. And I think a lot of times that has to do with oncologists when patients have pain or shortness of breath or issues like that. There's obviously many ways people suffer. But I think what's really challenging is how clinicians understand suffering and what the best approach is to respond respond to suffering are in the best patient-centered and therapeutic way?
I get that question a lot from my trainees in palliative care, not knowing what to do. And my first response is this is about how to be, not about knowing what to do, but how to be. In our medical training, we're trained often how to think and treat, but rarely how to be, how to accompany others. And I often have this image that I tell my trainees of instead of this hierarchical approach of a fix it mentality of all we're going to do, when it comes to elements of unavoidable loss, mortality, unavoidable sufferings, I imagine something more like accompaniment, a patient's walking through some dark caverns, and I am accompanying them, trying to walk beside them, shining a light as a guide throughout that darkness. So it's a spirit of being and walking with. And it's so tempting in medicine to either avoid the suffering altogether or potentially over identify with it, where the suffering just becomes so all consuming, like it's our own. And we're taught to instead strike a balance of authentic accompaniment through it. I often teach this key concept in my Pally Psych work with my team about formulation. Formulation is a working hypothesis. It's taking a step back and asking, why? Why is this patient behaving in this manner? What might the patient's core inner struggle be? Because asking that why and understanding the nuanced dimensions of a patient's core inner struggle will really help guide our therapeutic interactions and guide the way that we accompany them and where we choose to shine that light as we're walking with them. And oftentimes people think, well, Keri, that sounds so sappy or over sentimental. And it's not. I'm just thinking about a case that I had a couple months ago, and it was a 28-year-old man with gastric cancer, metastatic disease. And that 28-year-old man, he was actually a college Division I athlete, and his dad was an acclaimed Division I coach. In our typical open-ended palliative care questions, that approach infuriated them. They needed to know that I was showing up confident, competent, and that I was ready on my A game with a real plan for them to follow through. And so my formulation about them was they needed somebody to show up with that confidence and competence, like the Division I athletes that they were, to really meet them and accompany them where they were on how they were going to walk through that experience of illness.
These kind of insights are so helpful to think about how we manage something that we face every day in oncology care. And I think that there are many ways to manage this. Maybe ask Dr. Slawkowski-Rode one question just that I think sequences nicely with what you're talking about. But there's a lot of our patients are trying to think about sort of the bigger picture and how that might help clinicians understand and support patients. So the whole concept of spirituality, how can we really use that as oncology clinicians to better understand and support patients with advanced illness? And how can that help patients themselves? And we'll talk about that in two different ways, but we'll just start with this broader question.
I think spirituality, and here I usually refer to spirituality in terms of religious belief. Most people in the world are religious believers, and it is very intuitive and natural that religious beliefs would be a resource that people who help patients with a terminal diagnosis and healthcare professionals who work with those patients appeal to when they try to help them deal with the trauma and the stress of these situations. Now, I think that the interesting thing there is that very often the benefit of appealing to religious belief is misunderstood in terms of what it delivers. So my view here is that, and there are many, many studies on how religious belief can be used to support therapy and to support patients in getting through the experience of suffering and defeating cancer or facing a terminal diagnosis. There's a wealth of literature on this, but most of the literature focuses on this idea that by appealing to religious belief, we help patients and healthcare practitioners who are working with them get over the fact and that there's a terminal diagnosis determining the course of someone's life and get on with our lives and engaging with whatever other pursuits we might have, with our job if we're healthcare practitioners, and with the other things that we might be passionate about in our lives. And the idea here is that this is what religion allows us to do, because we sort of defer the need to worry about what's going to happen to us until the afterlife or some perspective beyond the horizon of our life here. However, my view is I have worked beyond philosophy also with theologians from many traditions. And my view here is that religion is something that does allow us to get on with our life, but not because we're able to move on or move past the concerns that are being threatened by illness or death, but by forming stronger bonds with these things that we value in our life in a way, and to have a sense of hope that these will be things that we'll be able to keep an attachment to despite the threat to our life. So in a sense, I think very many approaches in the field have the benefit of religion upside down, as it were, when it comes to helping patients and healthcare professionals who are engaged with their illness and treating it.
It's really interesting to the points that you make, and I think really important. But, sometimes the oncologists are really struggling with their own emotional reactions, how they are reacting to patients and dealing with sort of taking on the burden, which Dr. Brenner, you were mentioning earlier. How can oncologists be aware of their own emotional reactions? They're struggling with this patient who they're very attached to, who's dying, or whatever the situation is. But you want to avoid burnout as an oncologist, but also understand the patient's inner world and support them.
I believe that these affective emotional states, they're contagious. As we accompany patients through these tragic losses, it's very normal and expected that we ourselves will experience that full range of the human experience as we accompany the patients. And so the more that we can recognize that this is a normative dimension of our work, to have a non-judgmental stance about the whole panoramic set of emotions that we'll experience as we accompany patients with curiosity and openness about that, the more sustainable the work will become. And I often think about the concept of countertransference given to us by Sigmund Freud over 100 years ago. Countertransference is the clinician's response to the patient, the thoughts, feelings, associations that come up within us, shaped by our own history, our own life events, those unconscious processes that come to the foreground as we are accompanying patients with illness. And that is a natural part of the human experience. Historically, countertransference was viewed as something negative, and now it's actually seen as a key that can unlock and enlighten the formulation about what might be going on within the patient themselves even. I was with a patient a couple weeks ago, and I found myself feeling pretty helpless and hopeless in the encounter as I was trying to care for them. And I recognized that countertransfer within myself that I was feeling demoralized. And it was a prompt for me to take a step back, get on the balcony and be curious about that, because I normally don't feel helpless and hopeless caring for my patients. Well, ultimately, I discovered through processing it with my interdisciplinary team that the patient likely had demoralization as a clinical syndrome. And so it's natural many of us were feeling helpless and hopeless also accompanying them with their care. And it allowed us to have a greater interdisciplinary approach and a more therapeutic response and deeper empathy for the patient's plight. And we can really be curious about our countertransferences. A few months ago, I was feeling bored and distracted in a family meeting, which is quite atypical for me when I'm sharing serious illness news. And it was actually a key that allowed me to recognize that the patient was trying to distract all of us, talking about inconsequential facts and details rather than the gravitas of her illness. Being curious about these affective states really allows us to have greater sustainability within our own practice because it normalizes that human spectrum of emotions, and also allows us to reduce unconscious bias and have greater inclusivity with our practice. Because what Freud also said is that what we can't recognize and say within our own selves, that if we don't have that self-reflective capacity, it will come out in what we do. So really recognizing it, having the self-awareness and naming some of these emotions with trusted colleagues or even within our own selves allows us to ensure that it doesn't come out in aberrant behaviors like avoiding the patient, staving off that patient till the end of the day, or overtreating, offering more chemotherapy, or not having the goals of care, or doing everything possible when we know that that might result in medically ineffective care.
Yeah, I love the comments that you made, sort of weaving in Freud, but also I think the importance of talking to colleagues and to sharing some of these issues, because I do think that oncologists suffer from the fact that no one else in your life wants to hear about dying people. And
Yes.
they don't really want to hear about the tragic cases either. So I think that using your community, your oncology community, and greater community within medicine is an important part of being able to sort of process some of these important.
Yes. And Dr. Rugo, this came up in our ASCO section. I'd love to double click into some of those ways that we can do this that aren't too time consuming in our everyday practice. Within palliative care, we have interdisciplinary rounds where we process complex cases. Some of us do case supervision with a trusted mentor or colleague where we bring complex cases to them. My team and I, we offer process rounds virtually where we go through countertransference formulation and therapeutic responses on some tough cases. On a personal note, just last week when I left a family meeting feeling really depleted and stuck, I called one of my trusted colleagues and just for 3 minutes, constructively sort of cathartically vented what was coming up within me after that family meeting, which allowed me to have more of an enlightened stance on what to do next and how to be therapeutically helpful for the case. One of my colleagues calls this friend tours. They coined the phrase and they actually wrote a paper about it. Who within your peer group of trusted colleagues can you utilize and phone in real time or have process opportunities with to get a pulse check on what's coming up within us as we're doing this work?
Yeah, and it's an interesting question about how one does that, and maintaining that as you move institutions or change places or become more senior. It's really important. One of I think the challenges sometimes is that we come from different places for our patients. And that can be an issue, I think, when our patients are very religious and the provider is not, or the reverse, the patients who don't have religious beliefs and you're trying to sort of focus on the spirituality, but it doesn't really ring true. So, Dr. Slawkowski-Rode, what resources can patients and practitioners draw on when they're facing death and loss in the absence or just different religious beliefs that don't fit into the standard model?
You're absolutely right that this can be an extremely problematic situation to be in when there is that disconnect of religious belief or more generally spiritual engagement with the situation that we're in. But I just wanted to tie into what Dr. Brenner was saying just before. I couldn't agree more. And I think that a lot of healthcare practitioners, oncologists in particular, who I've had the pleasure to talk to at ASCO and at other events as well, very often quite skeptical about emotional engagement in their profession. They feel as though this is something to be managed, as it were, and something that gets in the way. And they can often be very critical of methods that help them understand the emotions and extend them towards patients because they feel that this will be an obstacle to doing their job and potentially an obstacle also to helping patients to their full ability if they focus on their own emotions or the burden that emotionally, spiritually, and in other ways the illness is for the patient. They feel that they should be focusing on the cancer rather than on the patient's emotions. And I think that a useful comparison, although, perhaps slightly drastic, is that of combat experience of soldiers. They also need to be up and running and can't be too emotionally invested in the situation that they're in. But there's a crucial difference, which is that soldiers are usually engaged in very short bursts of activity with the time to go back and rethink. And they often have a lot of support for this in between. Whereas doctors are in a profession where their exposure to the emotions of patients and their own emotions, the emotions of families of patients is constant. And I think that there's a great danger in thinking that this is something to be avoided and something to compartmentalize in order to avoid burnout. I think, in a way, burnout is more sure to happen if your emotions and your attachment to your patients goes ignored for too long. So that's just following up on Keri's absolutely excellent points. As far as the disconnect, that's in fact an area in which I'm particularly interested in. That's where my research comes in. I'm interested in the kinds of connections that we have with other people, especially in terms of maintaining bonds when there is no spiritual belief, no spiritual backdrop to support this connection. In most religious traditions, we have the framework of the religious belief that tells us that the person who we've lost or the values that have become undermined in our life are something that hasn't been destroyed permanently, but something that we can still believe we have a deep connection to despite its absence from our life. And how do you rebuild that sense of the existence of the things that you have perceivably lost without the appeal to some sort of transcendent realm which is defined by a given religion? And that is a hard question. That's a question, I think, that can be answered partly by psychology, but also partly by philosophy in terms of looking at who we are as human beings and our nature as people who are essentially, or as entities that are essentially connected to one another. That connection, I believe, is more direct than the mediation of religion might at first suggest. I think that we essentially share the world, not only physically. It's not just the case that we're all here, but more importantly, the world that we live in is not just the physical world, but the world of meanings and values that help us orient ourselves in society and amongst one another as friends and foes. And it is that shared sense of the world that we can appeal to when we're thinking about retaining the value or retaining the connection with the people who we have lost, or the people who are helping go through an experience of facing death. And just to finish, there's a very interesting question, I think, something that we possibly don't have time to explore, about the degree of connection that we have with other people. So what I've just been saying is something that rings more true or is more intuitive when we think about the connections that we have to our closest ones. We share a similar outlook onto the world, and our preferences and our moods and our emotions and our values are shaped by life with the other person. And so appealing to these values can give us a sense of a continued presence. But what in those relationships where the connection isn't that close? For example, given the topic of this podcast, the connection that a patient has with their doctor and vice versa. In what sense can we talk about a shared world of experience? Well, I think obviously we should admit degrees to the kind of relationship that can sustain our connection with another person. But at the same time, I don't think there's a clear cutoff point. And I think part of emotional engagement in medical practice is finding yourself somewhere on that spectrum rather than thinking you're completely off of it. That's what I would say.
That's very helpful. And I think very helpful way of thinking about how to manage this challenging situation for all of us. One of the things that really, I think, is a big question for all of us throughout our careers is when to address the dying process and how to do that. Dr. Brenner, what to do when, I still struggle with this, what to do when patients refuse to discuss end of life, but they're very close to end of life. They don't want to talk about it. It's very stressful for all of us, even where you're going to be, how you're going to manage this. They're just absolutely opposed to that discussion. How should we approach those kinds of discussions? How do we manage that? How do you address the code discussion, which is so important? These patients are not able to stay at home at end of life in general. So you really do need to have a code discussion before you're admitting them. It actually ends up being kind of a challenge and a mess all around. Would love your advice about how to manage those situations.
I think that's one of the most piercing and relevant inquiries we have within our clinical work and challenges. I often think of denial not as an all or nothing concept, but rather as parts of self. There's a part of everyone's being where the unconscious believes it's immortal and will live on forever. And yet we all know intellectually that we all have mortality and finitude and transience and that time will end. We often think of this work as more iterative and gradual and exposure-based. There's potency to words. Saying you are dying within days is a lot higher potency of a phrase to share than this is serious illness, this illness is incurable, time might be shorter than we hoped. And so the earlier, more upstream we begin to have these conversations, even in small, subtle ways, it starts to begin to expose the patient to the concept so they can go from the head to the heart, not only knowing their intellectual prognosis intellectually, but also affectively to integrate it into who they are as a person. Because all patients are trying to live well while also we're gradually exposing them to this awareness of mortality within their own lived experience of illness. And that ideally happens gradually over time. Now, there are moments where the medical frame is very limited and we might have short days and we have to up titrate those words and really accompany them more radically through those high affective moments. And that's when we have to take a lot of more nuanced approaches. But I would say the more earlier and upstream, the better. And then the second piece to that question as well is coping with our own mortality. The more we can be comfortable with our own transience and finitude and limitations, the more we will be able to accompany others through that. And even within my own life, I've had to integrate losses in a way where before I go in to talk to one of my own palliative care patients, one mantra I often say to myself is, I'm just a few steps behind you. I don't know if it's going to be 30 days or 30 years, but I'm just a few steps behind you on this finite, transient road of life that is the human experience. And that creates a stance of accompaniment that patients really can experience as they're traversing these tragedies.
That's great. And I think those are really important points and actually some pearls, which I think we can take into the clinic. I think being really concrete when really the expected life expectancy is a few days to a couple of weeks can be very, very helpful. And making sure that patients hear you, but also continuing to let them know that as oncologists, we're here for them. We're not abandoning them. I think that's a big worry for many, certainly my patients, is that somehow when they would go to hospice or be in no code that we're not going to support them anymore or treat them anymore. That is a really important process of that as well. And of course, engaging the team makes a big difference because the whole oncology team can help to manage situations that are particularly challenging like that. And just as we close, I wanted to ask one last question of you, Dr. Brenner, that suffering, grief, and burnout, of course, you've really made the point that these are not problems to fix, but dimensions that we want to attend to and acknowledge as part of our lives. The dying process is part of all of our lives. It's just dealing with this in the unexpected and the, I think, unpredictability of life, that people take on a lot of guilt and all sorts of things about all sorts of emotions. And the question is now, people have listened to this podcast. What can they take back to their oncology teams to build a culture that supports clinicians and their team at large to engage with these realities in a meaningful and sustainable way? I really feel like if we could build the whole team approach where we're supporting each other and supporting the patients together, that will help this process immeasurably.
Yes. And I'm thinking about Dr. Slawkowski-Rode's observation about the combat bad analogy. And it made me recognize this distinction between suppression and repression. Repression is this unconscious process. And this is what we're taught to do in medical training all the time, to just involuntarily shove that tragedy under the rug. Just forget about it and see the next patient and move on. And we know that if we keep unconsciously shoving things under the rug, that it will lead to burnout and lack of sustainability for our clinical teams. Suppression is a more conscious process, that deliberate effort to say, this was a tragedy that I bared witness to. I know I need to put that in a box on the shelf for now because I have 10 other patients I have to see. And yet, do I work in a culture where I can take that off the shelf during particular moments and process it with my interdisciplinary team? Phone a friend, talk to a trusted colleague, have some trusted case supervision around it or process rounds about it talk to my social worker. And I think the more that we model this type of self-reflective capacity as attendings, folks who have been in the field for decades, the more we create that ethos and culture that is sustainable, because clinician self-reflection is never a weakness. Rather, it's a silent strength. Clinician self-reflection is this portal for wisdom, connectedness, sustainability, and ultimately transformative growth within ourselves.
That's such a great point. And I think this whole discussion has been so helpful for me. And I hope for our audience that we really can take these points and bring them to our practice. I think thinking, wow, this is such a great conversation. I'd like to have the team as a whole listen to this as ways to sort of strategize, talking about the process, our patients, and being supportive as a team, understanding how we manage spirituality when it connects and when it doesn't. All of these points are bringing in how we process these issues and the whole idea of suppressing versus sort of deciding that it never happened at all is, I think, very important, because that's just a tool for managing our daily lives, our busy clinics, and everything we manage.
And Dr. Rugo, it's reminding me at Stanford, we have this weekly practice that's just a ritual where every Friday morning for 30 minutes, our social worker leads a process rounds with us as a team, where we talk about how the work that we're doing clinically is affecting us in our lives in ways that have joy and greater meaning and connectedness, and other ways that might be depleting. And that kind of authentic vulnerability with one another allows us to show up more authentically for our patients. So those rituals, that small 30 minutes once a week, goes a long way. And it reminds me that sometimes slowing things down with those rituals can really get us to more meaningful, transformative places ultimately.
It's a great idea. And I think, making time for that in everybody's busy days where they just don't have any time anymore is important. And you don't have to do it weekly. You could even do something monthly. I think there's a lot of options, and that's a great suggestion. I want to thank you both for taking your time out for this enriching and incredibly helpful conversation. Our listeners will find a link to the EdBook article we discussed today, which is excellent, in the transcript of this episode. I want to thank you again, Dr. Brenner and Dr. Slawkowski-Rode, for your time and for your excellent thoughts and advice and direction.
Thank you very much, Dr. Rugo.
Thank you.
And thanks to our listeners for joining us today. Please join us again next month on By the Book for more insightful views on topics you'll be hearing at the education sessions from ASCO meetings and our deep dives on new approaches that are shaping modern oncology.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.